Today's video we'll discuss about aortic valve stenosis. So as the word stenosis suggests, it is the narrowing of aortic valve which leads to obstruction of flow of blood from left ventricle to the ascending aorta. Now coming on to the etiology, the causes. Etiology. To understand the etiology, we will divide them into two. First one is aortic valve stenosis occurring in infants, children, and adolescents. And the another one is occurring in the adults. So basically, in infants, children, and adolescents, it can always be congenital, and even in congenital, we have three. The first one is the valvular, then is the subvalvular, and then is the supravalvular. In adults, it can be due to three reasons. The first one is congenital. In congenital, we can have a calcific bicuspid valve, or we can have a non-calcific fibrotic bicuspid valve. This is the first one. Then coming on to the second cause, which is rheumatic. And the third one is senile degenerative aortic stenosis. Senile, मतलब old, with age. So this is the etiology. Now coming on to the pathophysiology. How is it affecting? Now in the pathophysiology, first we must understand that we have left ventricular and left atrium. Now in this, what we see is there is a decrease in the flow. So in the left ventricular, what we'll see is there will be a left ventricular outflow obstruction, due to which there will be an increase in the left ventricular systolic pressure, and there will be a decrease in the aortic pressure. Since there is an increase in the left ventricular systolic pressure, so what we'll see is left ventricular hypertrophy. It will increase in the size. This will lead to left ventricular dysfunction, which will lead to left ventricular failure. Now this will lead to myocardial ischemia because enough of the blood is not being pumped, due to which ischemia occurs. Now these reasons might also lead to myocardial ischemia. Now as a result, it will result in left ventricular failure. Now coming on to the clinical features. In clinical features, what we see in the symptoms is exertional dyspnea, angina, cough, hemodiasis, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, exertional syncope. We can also expect sudden death. In case of signs, what we see is the pulse. It becomes very low and chaotic, slow rising. A keyword here to remember is pulse, porous, or tardus. Then there will be increase in the jugular venous pressure. Then we might also see low pulse pressure, ankle edema. Now coming on to the examination part. We know we do it in four. The first one being inspection, second one being palpitation, third one being percussion, fourth one being auscultation. What we'll see is the apex beat will be normal, but it will be displaced to the fifth intercostal space. Over here, what we'll see is a systolic thrill will be present in the aortic area, that is basically the neck area. So, and we will also see a left ventricular thrust which will be palpable, and there will be tender hepatomegaly. In percussion, what we'll see is cardiac dullness. And in auscultation, first we have an ejection click, then the S2 will be soft and feeble. Then there will also the mid systolic murmur, ejection murmur. It will be diamond shaped, and we might also see competition at the base. Now, coming on to the other investigation, in ECG, we'll see there will be left atrium hypertrophy, left ventricular hypertrophy. Then we also might see ST and T changes, which indicate myocardial infarction. Then left bundle branch block can also be seen. In the chest X-ray, what we'll see is there will be pulmonary congestion, or it will be normal. And in chest X-ray, sometimes the heart can be enlarged. In echocardiography, what we'll see is left ventricular enlargement and calcification of valves. Then we can also do Doppler echocardiography. In this, we'll see that there will be a systolic gradient present across aortic valve, and there is absence of aortic regurgitation. We can also perform cardiac catheterization. Now, coming on to the management. As told before, one is medical and the other one is surgical. In medical, you need to remember that digoxin is not given in this. We might give an antibiotic prophylaxis, anticoagulants. And in case of surgical, as told before, we can do balloon valvuloplasty. We basically have to increase the area. This is only indicated when there is symptomatic atrial stenosis. If the pressure gradient is more than 60 mm across the valve and we have a normal cardiac output, or we can also but we can we'll do these in case of valve replacement because they are more severe. Balloon valvuloplasty we'll do when we have a less severe case, which is congenital non calcific aortic stenosis.